Yan, reason why it's a mini lecture, it's because makalimutan ko lang alisin yung mini. Hindi. Okay. So let's start. So good afternoon, everybody. I hope that you had a good start of the year lecture. Thank you, Dr. Candelaria, for covering up for me. I just finished an operation. So today we'll be talking about the abdomen. I know that this is your goal. This is your goal, abdomen, to have six packs. But how do you actually get that? Actually, you can get that if you know the composition of the anterior abdominal wall, so that you know which muscles to activate and So no amount of intermittent fasting might get you this one, this kind of body. You have to also exercise. Anyway, I'm an anatomist and a general surgeon by practice. So this next slide is a patient of mine. She's a sex bomb babe. Kung ano man tawag sa kanila. Anyway, she had been a patient of mine for since 2017, and this is how she looks like. However, because she had a baby and sinisi sa baby and she loves eating, her abdomen, she had an umbilical hernia. So yung pusod niya that you can see here, nagkaroon ng itong umbilicus niya, nagkaroon ng protrusion. So you can see that the protrusion is not only because it's genetic, but also because she lacked protein. Because during this time that she was modeling and she was dancing, she went into fasting kasi ayaw niya magkaroon ng fats. She's also an FHM model. Yun, and she never recovered her body. So what happened is I did a surgery on her. So, pwede pala itong i-play. Let's play this. This is actually the bulk of our topic for today. Yan. As you can see that we are dissecting the layers of the abdominal wall. So that's one topic for today. The walls of the anterolateral abdominal wall. You can see that as we are dissecting, we dissect it layer by layer. So we started with the skin, and now I'm dissecting on the subcutaneous tissue. So what's held by the mosquito there is the umbilicus. I'd like to go to the...
Okay, mamaya na ulit. Thank you.
Ayun. I'd like to... I usually go to the thinnest portion of the abdomen so that during repair, hindi ako mahihirapan na to bring them together, to oppose them again. So this is what I do, and I do love what I'm doing. I don't think I could be able to repair this ventral wall hernia if I don't have a firm grasp of the anatomy of the anterior abdominal wall. So I wouldn't be doing an approximation of the abdominal girdle if I do not know the layers of the skin, or the skin, the fats, and the fascia, and the muscles that are the layers of the anterior abdominal wall. So what we can see here, I hope that you were able to read during the vacation, but maybe that's kind of a tall order. But these are the topics that we will discuss. So if you want to do a screenshot of this, please, you may do so that you have a checklist of what we've covered today. So what is the main function of the abdomen? The main function is to keep the organs in place and to accommodate these organs as they expand during eating, pregnancy, or accumulation of fats. So that's the function of your anterior abdominal wall, anterolateral abdominal wall. And to control and to hold on to the abdominal content despite the increases in abdominal pressure. Ayan, ulit. Next slide is the sagittal images of the abdominal cavity. The abdominal cavity, so you have your abdominal pelvic cavity. So your abdominal cavity forms the superior and major part of the abdominal pelvic cavity. which is the continuous cavity that extends between the thoracic diaphragm and the pelvic diaphragm. So this is your thoracic diaphragm. Yan. This is the thoracic diaphragm. And this is the pelvic diaphragm. There. Okay. So that is the extent of your abdominopelvic cavity. It has no floor. The abdominal cavity has no floor of its own because it shares it is continuous with the pelvic cavity. And it extends superiorly into the osteocartilaginous thoracic cartilages. See how it see that the ribs actually covers a portion of your abdominal organ. So it extends superiorly into the osteocartilaginous thoracic cage up to the fourth intercostal space, and it protects the rib actually protects the more superiorly placed organs. And what are these? These are your stomach, portion of the stomach, your spleen, your liver, part of the kidneys, and these are protected by your thoracic cage. Now, posteriorly, you have a greater pelvis that supports the lower abdominal viscera, what are the lower abdominal viscera? Pagka alam ninyo, you can unmute. But I will say them again. You need to know these, okay? Which organs are protected, located where, kunwari, in the pelvic area. You have your ileum, your cecum, your appendix, your sigmoid colon, and your rectum. These are within the greater pelvis. Okay? So that's the importance of this sagittal image. So when you see so you should be able to identify. Later, I'll show you a technique. I've been demonstrating this during the laboratory. It's when I say that you have to know a certain part. You have to be sure that it is, for example, in this sagittal portion of the body, we can't really say which organs is what, diba? But I am sure, I'm 100% sure that this is your liver. And from there, I will deduce. So underneath the liver, your small intestines could be there. Or your transverse colon, which is anteriorly located. So that's how we study gross. Okay. Now here is this is This is an image lifted from Moore 7th edition, showing the abdominal regions of your abdominal regions and abdominal quadrants. What's important here? This is very important because when you see a patient at the emergency department, you don't immediately say, "Oh, let's bring him or her to the operating room and let's see which organs are punctured or perforated." No, we don't do that. Or we don't really say na, oh, sige, meron siyang epigastric pain. Okay, let's go bring him to the OR and see which organs are damaged. No, when you hear a patient complaining in a certain quadrant of the abdomen or the areas of the anterior abdomen, you will have an idea which organs are actually affected. So you have your abdominal regions. So let's go first into this. There are 9 regions of the abdominal cavity. So 1, 2, 3, 4, 5, 6, 7, 8, 9. You have, it's used to describe the location of the abdominal organs. It's pains and therefore theorized which organs are pathologic. These regions are delineated by 4 planes. You have 2 sagittal and 2 transverse. So 1, 2 sagittal and 1, 2 transverse. The 2 sagittal planes are usually the mid-clavicular planes that passes from the midpoint of the clavicle down to the mid-inguinal point. So midpoint of the clavicle to the inguinal points. So dalawa yan. And then you have your transverse planes these are subcostal planes passing through the inferior border of the 10th ICS, 10th costal cartilages on each side. So these are your transverse. And you also have your transtubercular planes passing through the iliac tubercles and the body of the L5 vertebra. So that's one. Okay. So actually you also there's another way, but I'll show you in the next slide. So but first there's another way of identifying the regions of the abdominal regions. No, but that's on the next slide. But let's look here on the right side of the image. You have your quadrants, your abdominal quadrants, which are most commonly used in describing location in the abdomen. Maybe let's give you an example. So you have a lesion here. It's a red discoloration about 1 centimeter. How do you describe it? How do you tell a doctor that this is what you see? How do you tell your consultant that this is what you see? Or how do you write a description on the paper? This is a 1 cm flat lesion of the skin. Anyone? Anyone? Casimiro. Biglang nagtawag eh. Anyway, spare me calling out names. Just unmute and describe this lesion that I'm pointing at. Wala? Buksan nyo kaya yung mga ano nyo. Caitlin Kambay, can you describe this lesion? From 1A. You don't have to open your video, just unmute and give a description. Naririnig nyo ba ako? Naririnig nyo naman ako eh, di ba? Okay, Lawrence, thank you. Please unmute and describe it.
The 1 centimeter flat lesion on the upper left quadrant.
Left upper quadrant. Okay. That's all I wanted. Thank you so much. Because that's what we need. That's what you will do when you pass your board exam or when you go clinical. You indicate you just indicate the location of the lesion. Okay? Medial or lateral pertains to the location, but now we're just focusing on the quadrants. So we can do that later. Anyway, that's how you do it. You describe and you say the location. Kunwari, epigastric pain. Pain siya dito. Abdominal pain located at the epigastric area. Tapos yung rating naman of pain. Pain scale, 4 out of 5. Mga ganon. Okay? So this is how important knowing these planes, abdominal areas are. So that's very important because that is how we will speak if you refer someone to me or to your consultants. So there's another way. You have your transpyloric plane or your Addison's plane. So what is a transpyloric plane? Itong naka-red. Underlined in red. Yan. So your transpyloric plane, also known as the Addison's plane, is usually traverses many important structures. And these structures include the fundus of the gallbladder, the neck of the pancreas, the origin of your superior mesenteric artery and hepatic portal vein, the root of your transverse mesocolon. It's actually listed in your Schwartz. It's listed in your Schwartz is a surgical book, but it's also listed in more. Duodenal junction and hyla of the kidneys. So this transpyloric plane traverses all these important structures. That's why the surgeons actually prefer to use the transpyloric plane as indicators. The transpyloric plane is 1/3 way from the jugular notch to the symphysis pubis. So 1/3 jugular line. Ito, 1/3. So, nakikita nyo ba yung mga annotations ko? Yan. So that's 1/3 from the clavicle down to your symphysis pubis. Now, iba naman yung transverse plane. Ang partner niya ay the interspinous plane. Okay? So, you might confuse yourself during the theoretical exam. So, this might not be asked in the practical exam, but definitely will be asked in the theoreticals, no? So, the transpyloric plane, ang kapartner niya ay in the interspinous plane. The other one, the one I showed you previous slide, would be your midclavicular line is paired with your subcostal plane and your subcostal plane. Okay, but the transpyloric plane, interspinous plane. All right. So the surgeons would prefer your transpyloric plane as baseline because it traverses a lot of important structures, clinical structures, that when you have an injury at this area that traverses your transpyloric plane, it's most likely surgical. Most likely surgical. Okay? All right. Oh, macho naman ito. So, sige, exercise tayo, exercise. So, meron siyang pain dito. What do you think? What are the most likely pathology for that?
Appendicitis po.
Appendicitis, where is it located? So you can describe it. There is a 4 out of 5 pain located at the
Right lower quadrant.
Right lower quadrant.
yes. So when you say to your doctor or your ER attending that there is a patient with right lower quadrant pain, ang iniisip mo kaagad is appendicitis because that is where your appendix is located. So next slide is a table of the organs that are located in the different quadrants. So if there is pain at the left upper quadrant, what are the possible, these are the list of the possible injury. So when you draw an abdomen, umbilicus, tapos ang pain mo ay nandito sa left upper quadrant, then you can work on the organs that are at the left upper quadrant. If it's more posteriorly located or at the back, then you can look at the organs that are located at the back. Mostly pag anteriorly located ang pain, if the pain is anteriorly located, then you can assume that these are the organs that are anteriorly located also. But do not discount the presence of your referred pain. Okay, so dito, tama ka, the pain was here. So it could be either your cecum, your appendix, a part of your ileum, your ascending colon. If it's a female, kanina kasi male picture, no? Pagka female yan, you have your right ovary, your fallopian tube, your ureter, right ureter for both sexes. Or your uterus for female, mga ganon. Okay? So, the abdominal wall is continuous, but for descriptive purposes, it is subdivided into the anterior wall, right and left lateral wall, and posterior walls. Ito na pala dapat. So, the wall is musculoaponeurotic. except for the posterior portion, except for the posterior wall, which includes the lumbar region of the vertebral column. As you can see, the boundary between the anterior and the lateral wall is indefinite. Therefore, the term anterolateral abdominal wall is used instead of just the anterior wall of the abdomen. So why infinite? Because there is intertwining of the muscles that are located at the lateral aspect. Except, of course, yung straight muscles mo, which are the rectus, which I will show you later on. So here, so these are the layers of the abdominal wall that you can see on your screen. The subcutaneous tissue includes a variable amount of fat. So you have the skin first and then your subcutaneous tissue. And it is the major storage for fat. Males are usually susceptible to this accumulation at the lower abdominal wall, lower anterior abdominal wall. Okay. Question? Wala. Sige. This next slide is a photo. It's just a photo lang ba to? Yeah, it's just a photo of the same surgery I did at the opening. I remember the video of the FHM model that I did. So this is after opening the abdomen. This is your skin. This is your, paano ba ibahin yung color? Subcutaneous tissue. And then this is your fascia. How do you change the color of the pen? Wait. Hold on. Okay, let's change the color. So this one, when I open, this is the defect I found. So that is the umbilical defect. Remember, I placed a mosquito at the level of the umbilicus so that I will remember. Ito yun, no? Yan yung puso niya talaga. But when I released it and removed it, I saw a 5 centimeter defect at the anterior abdominal wall starting at the umbilicus. Yon. Okay? So superior, where is superior? This is superior. Itong may arrow. The subcutaneous tissue is found consistently in most regions. Inferior to the umbilicus, this is the inferior to the umbilicus, the one with the Richardson instrument to retract. The deepest part of the subcutaneous tissue is reinforced by many elastic and collagen fibers at the inferior to the umbilicus. Hence, we have 2 layers of the subcutaneous tissue. You have your superficial fatty layer or Camper's fascia and the deeper membranous layer, which is your Scarpa fascia of the subcutaneous tissue. Okay, so this is an example, but I think, but may question ba kaya about this picture? Wala naman masyado, no? Because I don't want to get too clinical. But this is what I see. And what I did is I removed the defect. I did not remove the defect. I repaired the defect. I removed the fat. And tucked it inside the abdomen and sutured the defect. Yung green outline yon, pinagdikit ko yon. And then I inserted a mesh to reinforce. Okay. So let's compare these. Oh. You have 5 bilaterally paired muscles in the anterior abdominal wall. You can see this in your textbooks, okay? But the next slide, I would like to show you. Yan. Okay. Hindi ko lang compare side by side, but maybe I can write on it. So you have 5 bilaterally paired muscles in the abdominal wall. The first 3 are the flat muscles. So first is your external oblique. The first 3 are flat muscles, and these are continued anteriorly and medially as a sheet-like aponeurosis. So we also have you have your external oblique, your internal oblique, and your transversus abdominis muscle. And then you have a tendinous rectus sheath enclosed by, this is your, enclosed by the rectus, enclosing, I'm sorry, you have the a rectus sheath enclosing your rectus abdominis muscle. And you have the aponeurosis that interweaves with the opposite side, forming a median raphe. So this is your median raphe, and you call that your, it's not here, but you call that your,
Linya
yeah,
alba po.
correct, that's your linea alba. Okay, so we have two vertical muscles of the anterolateral abdominal wall within the rectus sheath. No? So these are your rectus abdominis muscle and your, the triangular muscle in this area. Dalawa yan.
Pyramidalis po.
Pyramidalis muscle. Your pyramidalis muscle is a small muscle pero paired sila lahat. Okay? So the pyramidalis is a small, insignificant triangular muscle that is absent in 20% of people. So, which also means that you can see it in 80% of people. It lies under, why is it insignificant? Because it doesn't do much service. Doesn't do any, I can't say that it doesn't do anything, but in terms of muscle contraction and curving or carrying the weight of the body, it doesn't do anything, even if it's contracted. So it lies anterior to the inferior part of the rectus abdominis muscle and attaches to the anterior surface of the pubis and the anterior pubic ligament. And it ends at the linea alba. Yan. So these are your linea, this is your linea alba. That divides into two. This is a picture of an infection. Yung left side, it's infected. So may makita kayo dyan, that's an abscess. But because of the infection, nakikita nyo tuloy, engorged yung muscle layers niya. So this is your rectus abdominis muscle, and you can see your external oblique. Oh, sorry, internal oblique. Pocket out. Dapat ganon yung internal oblique. External oblique pa ganyan, internal oblique, ito. So, wala siyang external oblique masyado. Probably because of the infection. Nung dinibri siya. Okay, next slide. Okay, this is a tabulation of the important muscles of the abdominal wall, which you should be an expert of by the end of this week. So you have your external oblique, internal oblique, transversus abdominis muscle, and your rectus abdominis muscle. Don't forget your pyramidalis muscle. I think there is one cadaver wherein you can find it. But let's see yung prosected one meron na pyramidalis. Okay, don't forget to take note of the main action and the innervation. Oh, what's this? Oh, this is another surgery of mine. Well, like what I said, you look at the picture as if you look at the picture and find one structure that you are sure that it is what it is. So for example, here, this is your, this is the skin. Ang hirap kasi, no? But this one is definitely a liver lobe, which means this will be your gallbladder. That should be the location of your gallbladder. Kasi kung ito, if this is your left liver lobe, this should be your right lobe. of the liver. And this is your mesentery, the fatty layer that we will discuss later on. So what you can see here is a necrotic gallbladder. Okay? So when I opened, no joke, I found this in a patient and I thought that I'll be doing a simple cholecystectomy. But then, good thing I did an open type because that's the patient's preference. So the the management of cholecystectomies should be laparoscopic now. It's what we do now. But sometimes if it's the patient's preference and they would want you to open instead of do laparoscopic, then we do that. So this one, when I opened, I see a necrotic gallbladder. So I would not identify that if I didn't know the structures. Yeah. Anyway. Yon. So here, this is another image from your more. What I would like to show you here is at approximately 1/3 of the distance from the umbilicus to the pubic crest. The aponeurosis of the three flat muscle pass anteriorly to the rectus abdominis to form the anterior layer of the rectus sheath. So, yung aponeurosis, do you know what aponeurosis means? Pagsasama-sama, pagkakadikit-dikit, they like flow together. They are intertwined. The fibers are intertwined. Hindi mo mapaghihiwalay. Okay? So this 1/3. So your posteriorly, after this one, this is the 1/3 I'm talking about. There is a thin transversalis fascia to cover the rectus abdominis muscle at this level. But everything up there, in this portion, everything from here upward, everything from the arcuate line upward, you have your anterior rectus sheath and your posterior rectus sheath. So a crescentic arcuate line demonstrates the transition between the aponeurotic posterior wall of the sheath of your rectus sheath, covering the superior 3/4 of the rectus, and the transversalis fascia naman inferiorly. So this one, upward, above your arcuate line, you have your posterior rectus sheath. That is where your rectus abdominis muscle lie. But here below, let's call this the Y layer. Here below, that would be your transversalis fascia instead, where your rectus abdominis muscle lies. Okay, so gets mo yun na, arcuate line is a landmark. Another structure to point out is the linea alba that you've already mentioned. It is an interlacing of the anterior and posterior layers of your rectus sheath all throughout the length of the sheath. So this is, hindi kita yung superior part. So here, this is a cadaveric photo. Why did I show this? No, I just like to show you the arcuate line here. So this is your linea alba, right? So this is the arcuate line. So everything below here, it's just this transversalis fascia, but this one would be your posterior rectus sheath. You get that? I hope you do. Okay, what about this? What's this muscles? What's this muscles? What is this? This is your inferior epigastric artery. Inferior epigastric artery. O bawal ang ganyang abbreviation That inferior epigastric artery exits goes into the rectus sheath, and it exits. It passes. It will be visible right above the arcuate line. Okay, so lumalabas siya dyan. Anyway, next slide. So these are the vessels of the anterolateral abdominal wall. It's listed. You have 4 that you should be able to find. Your superior epigastric vessels, your inferior epigastric and deep circumflex iliac vessels. Ito yan. So inferior epigastric and deep iliac vessels. You have your superficial circumflex iliac vessels and your posterior intercostal vessels. So you can see here your superior epigastric artery, your inferior epigastric artery, your circumflex iliac superficial, and your superficial epigastric artery. So you can see that your rectus abdominis has two blood supplies, and muscles that have 2 blood supplies are great sources of coverage for repair, reconstruction. Like for example, if you do a mastectomy, the nearest muscle that you can use to replace the breast with is, instead of using a synthetic breast, you can use your rectus muscle. So you just get it from here, right before the superior epigastric artery. Just make sure that you will not ligate the artery. So, and then you just transpose it to the breast and attach it, and you have your breast reconstruction. Okay, so that's the importance of the vessels. Okay, so this is a summary of your arteries of the anterolateral abdominal wall. Please take time to read them, and what's important here are the origin. Please take note of the origin and locate them at the during the gross lab exam. Okay, what's this? So now we go to the posterior or the internal surface of the anterolateral abdominal wall. Gross kagad, let's do the internal surface first. Okay, yung checklist natin, we're finished with the layers of the anterior abdominal wall. Now we go to the internal surface. It is covered with your transversalis fascia. A variable amount of extraperitoneal fat depends on how gifted you are with fatty layers, and parietal peritoneum. The infraumbilical portion, so below the umbilicus, shows 5 umbilical peritoneal folds passing toward the umbilicus. So 1 in the medial plane and 2 on each side. So median plane and 2 on each side. So you have your median umbilical fold. Not sure if you can see it, but you have your median umbilical fold, your medial umbilical fold, and your lateral umbilical fold. Okay? Your median umbilical fold extends from the apex of the urinary bladder. This is your urinary bladder to the umbilicus and covers the median umbilical ligament. Your median umbilical ligament is a remnant of your urachus that joins the apex of the fetal bladder to the umbilicus. Now, when a pediatric patient comes to you with weeping of the umbilicus, then you could suspect that there is patent urachus. because it's more common. It's more common than what's recorded. Now you have your two medial umbilical fold. Medial, so median, yung gitnang gitna. Medial, two medial umbilical folds that's lateral to the median umbilical fold that covers the medial umbilical ligament formed by the occluded umbilical arteries. So, median umbilical fold, remnant of the urachus. Medial umbilical fold covers your medial umbilical ligament formed by your occluded umbilical arteries. So, occluded umbilical arteries. And you have your two lateral umbilical folds that's lateral to the medial umbilical folds that covers the inferior epigastric arteries. Okay, so your urachus and your occluded umbilical arteries, these are cut or occluded or becomes remnant after birth. But your inferior epigastric artery, which is covered by your umbilical fold, is patent. So if you're at the level of the umbilical fold, of the lateral umbilical fold, if you cut it, it will bleed. Okay? Let me show you this. So here, if this is the umbilicus, you have here your median. You have two medial, ito median, two medial, and here, your lateral. Why is it lateral? Because this is where your inferior epigastric arteries are. Median, medial, and lateral. Okay? Sisipon ako. So you have, so knowing that your medial, medial, and your lateral, you should also know your fossa. You have your supravesical fossa, medial inguinal fossa, and your lateral inguinal fossa. Okay? So your supraumbilical part of the internal surface of the anterior abdominal wall has a sagittally oriented reflection, peritoneal reflection. There, that's called your falciform ligament. So it's lateral, it's at the level, it's a supraumbilical part. So if this is your umbilicus, that is your falciform ligament. It extends between the superior anterior abdominal wall and the liver. It encloses the round ligament of the liver, and the round ligament of the liver is a fibrous remnant of your umbilical vein. So, yon. After mentioning the falciform ligament, then we can go back to the peritoneal fossae. So the depressions, you can read here your supravesical fossa, your medial inguinal fossa, and your lateral inguinal fossa, and its corresponding defects. If you have a defect between the median and the medial umbilical folds, you have your supravesical hernia that causes intestinal obstruction, and it's extremely rare. But in areas or in female kasi lagi yung they don't take care of their muscles, right? They don't want to bulk up. But if you don't eat and you don't exercise, then you have weakened muscles. Then it's prone. You'd have increased chances of getting your supravesical hernia. And then your direct inguinal hernias, which is a product of the defect between the medial and the lateral umbilical folds. It's commonly known as the inguinal triangle of Hasselbalch. It is less common. The most common type of hernia is your indirect inguinal hernia. The indirect inguinal hernia is the most common type of hernia in the lower abdominal wall that is lateral to the lateral umbilical folds. That includes the deep inguinal rings. So that's just a summary. So here, yan. Let's go first to the inguinal canal. Yan. This is the inguinal region. There. It extends between, so we're done with the fossa, with the anterior abdominal wall, anterolateral abdominal wall. Now let's go to the inguinal region. So the inguinal region extends between the ascis and the pubic tubercle. There. Ascis, anterior, superior. Yan. And the pubic tubercle. So anatomically, the structures exit and enter the abdominal cavity through this inguinal region. And clinically, because that is where the structures normally exits, then this is a potential site of herniation. Why? Because you have the inguinal region, you have structures, and the structures includes your femoral vein, femoral artery. It exits your veins, and your nerves, they exit through the inguinal region. Okay, so these are potential sites of herniation. So your inguinal ligament and iliopubic tract is a bilaminar extensor. Yan, ito pala. Yan. You can see this is your anterior superior iliac spine. These are the natural structures that exits through the inguinal canal. Now the inguinal ligament, this is your inguinal ligament. And you can see this in your book, in your textbook. It's a dense band constituting the inferior-most part of the external oblique aponeurosis. So later on, I have a figure wherein you would see, kasi they all come, they don't just arise, they just change names as you go down the different regions of the abdomen. Okay? So this figure that you're seeing in your screen is lifted from more, illustrates the inguinal ligament, and here you can see that the ligament's medial end, they insert into the pubic tubercle. So this is the medial end. Okay? Now, some of the deeper fibers passes posteriorly to attach to the pubic ramus lateral to the tubercle, forming your arching lacunar ligament. So this is your arching lacunar ligament. There. Or lacunar ligament of Gimbernat. It forms the medial boundary of your subinguinal space. And the lateral of these fibers, they continue to run along the pecten pubis at the pecten ligament of Cooper. So, important ba to? Yes, important to, pero sa surgery, because that's when we do tissue repair, we have to identify the ligament of Cooper, the ligament of Gimbernat. But for your sake, it's we'll be asking you the basic questions for the inguinal canal. But don't be complacent because these basic questions are actually also difficult to remember sometimes. Some of the more superior fibers, they fan upward, bypassing the pubic tubercle and it crosses the linea alba. So ito yung medial, di ba? So linea alba mo nandito. They cross upward and bypass the pubic tubercle. We cross the linea alba to blend with the lower fibers of the contralateral external oblique aponeurosis. So there's continuity forming the reflected inguinal ligament. So ayan, ito yung mga reflections. So these fibers, they actually go everywhere. attached everywhere. Yan. The iliopubic tract is the thickened inferior margin of your transversalis fascia, right? So this is seen in the place of inguinal ligament when the inguinal region is viewed through a laparoscopy, during laparoscopy. That's when you can see the iliopubic tract through laparoscopy. Fortunately, I don't have an image for that. Now, one more thing. For here, you should the inguinal ligament and the iliopubic tract spans an innate weakness, right? I said because of the natural holes, the structures that bypasses this region. So you call this your myopectineal orifice. Your myopectineal that's outlined in green here. Yan. You can see that this is the site of the rect, indirect, and femoral hernias. Because of the natural site where the femoral arteries, veins, the femoral canal is, that is a potential weakness. And you call that your myopectineal orifice. Okay, now here, may abbreviation na kaagad no? MALT. MALT stands for two muscles. Muscles, you have two. A for aponeurosis. You have two. L for ligaments. You have two ligaments. And you have T. T structures, three T structures. The structure starts with the letter T. So what are these two structures? So these are the, what I'm showing you is the boundaries of the inguinal canal. So you have two muscles, internal oblique and your transversus abdominis muscle. And you can call this the superior border or the roof. Okay? The roof of the inguinal canal. And now you have two A's, two aponeurosis, and these aponeurosis are your internal oblique aponeurosis and your external oblique aponeurosis. And this would be in the anterior wall. Okay? So this one, kapag memorize mo na siya, then you would have the idea. It would be easy, but this one is kind of confusing, the inguinal area, inguinal ligament. So two L's, two ligaments, and these are your inguinal ligament and your lacunar ligament. And your T structures, two structures would be your transversalis fascia and your conjoint tendon, medial location. Okay? So that's just a shortcut. You can make a screenshot of this. But you also have this in more. It's in table 2.5 of more. Okay, hindi ko maano. Hold on. Yan. Nope. Nope. Yan. Boundaries of the inguinal canal. So just take note of this table and take note of this abbreviation, and I hope it'll help you. So what's important here is so in different areas of the inguinal canal, you have your lateral third, your middle third, and your medial third. There are different structures. So just take time to understand them and look at them through our laboratory sessions. Okay, and I'll be there also. Okay. So Oh, ito. Surgery ko din to, pero parang madugo. Well, this was during my training in PGH for bata pa yan, no? Maybe 3 years old. So that is a hernial sac that I exposed. No, you should have a good knowledge of the anatomy of the inguinal canal to be able to perform this kind of surgeries. So what this one is, that's your spermatic cord. Pinicturean ko lang. But this one is the hernial sac. So you can see that they have a big defect. It's about 1 centimeter. You can insert your pointer finger into the defect. Okay, so why am I showing you this? It's because we're on to the next part, the spermatic cord, scrotum, and testis. Now, on page 208 of your more, you could see this diagram that corresponds to the layers of the abdominal wall, the scrotum, and the spermatic cord. So I would like to teach you how to use this chart because the abdominal wall is not compartmentalized as we thought it is. It's actually a continuous layer. And because the abdominal wall is actually a continuous wall, that's why we call it your abdominopelvic region, the spermatic cord, scrotum, and testis. Now, let me clarify. This is not limited to the male sexes. There are female homologs. For example, Gartner's duct, which is an embryonic remnant of the female reproductive development. For the spermatic cord yun equivalent niya. So Gartner's duct is equivalent to the spermatic cord. Your labium majus or for the scrotum, and ovary for the testis, and so on. So let's proceed with the images. This is a cremasteric fascia based on the chart. So this is your chart. You can take a screenshot or look at your textbook. This is your cremasteric fascia, the one that's pointed by the Addison forceps. Based on the chart, it is derived from which layer of the abdominal wall? So cremasteric, okay? Let me go back. Baka kasi wala pa kayo sa book eh. O cremasteric fascia, it's derived from which layer of the abdominal wall? So cremasteric fascia is here. You just look at the red part also, and you can say that it's derived from the internal oblique muscle of the abdominal wall. O, gets nyo ba how to use this? Okay. What about based on this? Based on this image, well, this image is an image of hypospadias. Hypospadias is an abnormal condition wherein the penis is buried. It's yung common term niya kasi buried penis. No, what do you call the fascia that is covered in image A? Ay, mali. This one. This image. What do you call this fascia that covers the penis? That is actually your dartos fascia. And based on this structure, dartos fascia what is the continuation of your dartos fascia in the abdominal wall? Ito naman, subcutaneous tissue. Fatty or membranous subcutaneous tissue. Yeah. Okay, good. So that is how you use this chart. What about the tunica vaginalis? Meron ba akong image dito ng tunica vaginalis? Meron. Ayan. parietal tunica vaginalis. These are testes, no? So you have your parietal tunica vaginalis. Which layer is it? Oh, let's go back to the, dapat pala. Oh, let's go back to the chart. Correct. Your peritoneum. Okay. So with that, yung peritoneum, let's go to the peritoneum. Okay na tayo dito, no? That's how you do it. That's how we use this chart. And if you will have any more questions, you can write them down on the board that we have in Canvas. So your peritoneum, okay, your peritoneum is a continuous, glistening, slippery, transparent serous membrane. It lines the abdominal pelvic cavity and invests the viscera. You have two cavities, your peritoneal, your parietal peritoneum, and your visceral peritoneum. Those are the two layers. The parietal peritoneum is that which covers the anterior abdominal wall, the posteriormost layer of the abdominal wall, innermost layer, while your visceral peritoneum is one that covers the viscera, your liver, your intestines, your spleen, ganon. Now, intraperitoneal organs are almost completely covered with your visceral peritoneum. And your extraperitoneal or your retroperitoneal and subperitoneal organs are those outside the peritoneal cavity. Now, is there an organ that's completely outside the retroperitoneum, the peritoneal cavity? Yes, but there are only a few. So the peritoneal cavity is the one that's within the peritoneal cavity. Tignan mo to, even the kidneys, this is your kidney. You can say that those are the organs that are true retroperitoneal. But those in the middle, yung pancreas, ganon, only a portion of that is located retroperitoneally. And the head, and a part of the head is located there. Iba-iba kasi. The other textbooks will say otherwise, but we will follow more. Okay? So, your peritoneal cavity is within the abdominal cavity. It's continuous inferiorly into the pelvic cavity, and it houses a great length of gut covered by the peritoneum. So what are the gut or the intestines that are located retroperitoneally or not within the peritoneum? So these would be your rectum, your second portion of the duodenum, and so on. Due to the lengthening and growth of the intra-abdominal content and its continuities, there comes the peritoneal formation like the mesentery. So you have your peritoneum. Now because of growth and development, there is your formation of your mesentery. Your mesentery is a double layer peritoneum that is a product of invagination of the peritoneum by an organ, and it constitutes a continuity of the visceral and the parietal peritoneum. So there's still continuity. It's like how do we describe this? For example, parang yung tape candy, di ba? May lining siya na plastic. So even if you form them some other way, there are still two layers, no? So what happens is you have your candy, you have your plastic of candy, and the lateral aspects, the anterior and posterior peritoneum, or the peritoneum that covers it, they are folded together. They become adjacent to each other. So that's the mesentery. You have the double layer of the peritoneum. So your intestines covered by peritoneum, and then there comes a point wherein there's no intestine in between, and the peritoneum attaches to the other side of the of its peritoneum, it becomes your mesentery. So your mesentery is a double layer of peritoneum. It's invagination of the peritoneum by an organ. It provides, your mesentery actually provides a means for neurovascular communications between the organs and the body wall. Should I show this to you? O sige, show ko na lang. Show ko na lang. Next, yan. That is me. Ano ba to? Right? That's the ilium. We have a tumor located at the cecum. So this one, the one marked by an X, that is your mesentery. Okay? If this is the mesentery, this is your omentum. Okay? So the greater omentum, ito yan, lesser and greater omentum. So the greater omentum is a prominent four-layered peritoneal fat that hangs down like an apron. Why? Because you can see your stomach, it has its own mesentery, right? And your transverse colon also has its own mesentery. But then as the mesentery hangs down, it fuses with the transverse colon's mesentery, making them four-layered, forming the greater omentum. So it hangs down like an apron from the greater curvature of the stomach and the proximal part of the duodenum. And then after descending, it folds back and attaches to the anterior surface of your transverse colon and its mesentery. So sa stomach muna siya, goes down and folds back up to your transverse colon. Now your lesser omentum is a much smaller double-layered peritoneal fold that connects the lesser curvature of the stomach. If the greater omentum connects the greater curvature of the stomach to the transverse colon, your lesser omentum connects the lesser curvature of the stomach and the proximal part of the duodenum to the liver. It also connects the stomachs to the structure that runs between the duodenum and the liver in the free edge of the lesser omentum. Yeah, that is the lesser omentum. This one. Lesser omentum and greater omentum. Ano ba yan? Oh, this is the same image that I showed you. Pero parang mas maganda to. Yan. That is the greater omentum. Do I have a photo of the lesser omentum? Wala. Wala akong photo ng lesser omentum. But I will show it to you during the gross lab. Okay. Now let's talk about the peritoneal ligaments. Okay. So what's this again? Can you tell me what this is before I proceed? What is this marked with an X, green X? Anyone?
Peritoneum.
Ha? Tama ka naman. Ano yung sinabi mo?
Mesentery po.
Yes, and what about this one? Continue mo na rin. Mark with an Y. That would be your
Omentum.
omentum is correct, pero be specific. Yes, Kasumbal is correct. And Hernandez. Yeah, that's a greater omentum. Okay, now let's go to the peritoneal ligaments. And medyo marami pang slide, pero hindi, konti na lang to. These are your peritoneal ligaments. So just make a screenshot of that. Well, it's a summary. It's not from the textbook, but it's the source, HTTPS. Yan. Peritoneal ligament consists of a double layer of peritoneum that connects an organ with another organ or to the abdominal wall. Now, let's try to identify some ligaments. Okay, so sa liver, that which connects the liver would be coronary ligament from your falciform ligament, your round ligament, hepatogastric ligament, hepatic and gastric, no, connects the liver and the stomach. Hepatoduodenal, the liver and the duodenum. So stomach naman, you have your hepatogastric, gastrophrenic, stomach to the liver, stomach to the diaphragm, gastrosplenic to the spleen, and so on. And then your spleen, gastrosplenic, and splenorenal ligaments. Okay, let's try to identify some ligaments in the succeeding slides. Oh, ano yan? Ito, this one. Ay, green. Green. Red. What's this? Yan.
Falciform.
Falciform. Actually, dapat papunta siya dyan eh. Papunta sa umbilicus. Superior to the umbilicus. Pero ito, correct ka. This one, correct ka. That's the falciform ligament. But if I point here to this structure that's dense, ito. This is the original location of this structure. This structure is actually going toward the umbilicus. So what do you call that?
Round ligament.
Ligament po, Doc.
Okay, that's half correct kasi you have two round ligaments. So you say where it comes from. Round ligament of the...
Of the liver po.
Correct, that's the round ligament of the liver. Okay. What about this one? Yan. Diyan, ito. Nasa taas. Connects to the, this is your diaphragm, right? So
Coronary ligament.
correct, that's your coronary ligament. So the coronary ligament, the coronary ligament connects the liver to the diaphragm. Falciform ligament connects to the anterior abdominal wall. This falciform ligament, and this is your round ligament of the liver. It's a remnant of the fetal circulation. Eto, ay, so you can see here your hepatoduodenal. This is your hepatoduodenal ligament. Ito, liver and stomach. Liver and duodenum. Liver and duodenum. And then you have your liver to the stomach, hepatogastric ligament. Parang summary lang to ng kanina eh. Okay. Oh, let's try to identify some structures. Anyone, just unmute. What do you call this? Hello?
Greater omentum.
Greater omentum.
Very good. That's your greater omentum. And what about this? Tubular yan, ha? Yan. Ito.
Round ligament of the liver.
Very good. Round ligament of the liver. Okay. Okay na yan. Now, let's talk about the omental bursa or lesser sac. So greater omentum, it's considered your greater sac. But in your lesser omentum, when you open it, you can see your lesser sac or the omental bursa. So it's a hollow space. Hold on. It's a hollow space formed by your greater and lesser omentum and its adjacent organs. So it communicates with the greater sac by the epiploic foramen, and the epiploic foramen, yan, epiploic foramen of Winslow, which is known as the general cavity of the abdomen that sits within the peritoneum but outside of the sac. No, so you can see this foramen over here. So, syempre dinrowing ko na. But there's an opening. So, that opening is your that opening. So that space has well-defined borders that are represented by certain organs or their parts. So they're quite easy to spot and form a mental image of the omental bursa. So if we remove the lesser omentum here, this is what we see. There. So that space over there at the back of the stomach, anterior to your pancreas. So this is your pancreas. This is the posterior portion of your stomach. So that space is called your omental bursa. So your omental bursa is not a standalone and isolated entity, but rather it communicates with several organs and several other spaces and recesses found throughout the body. So that's the omental bursa. So just remember, teka, nandito ba? Wait. Wala na. Hindi ko siya nasama sa slide ko. But please make sure to read on the omental bursa. Okay, and its boundaries. What's important is the boundaries. So when we study the abdomen or the abdominal organs, it is important to note the boundaries of these structures. For example, what are the boundaries of what are the boundaries of the liver? No, what structures lie beside it, underneath and lateral to it? The stomach, and on. So these things we will discuss as we go along on our topic. So I'll also be discussing the foregut. So from the mouth down to the stomach. Okay? So I'll show it to you on the next lecture. Okay, now let's go to the posterior abdominal wall. So your posterior abdominal wall is covered with a continuous layer of endo-abdominal fascia that lies between your parietal peritoneum and the muscles. And it is continuous with your transversalis fascia that lines the transversus abdominis muscle. The fascia is usually named according to the structure that it covers. So we have the one that covers the psoas muscle. Ay, nagkulang. Sorry, psoas muscle. That would be your psoas fascia. What else? The lumbar fascia. Thoracolumbar fascia. That is attached to the vertebral column medially. Parang malabo lang tong isang to. Okay. So you have the muscles of the posterior abdominal wall. You have your psoas major, your iliacus muscles, and your quadratus lumborum that you should be able to identify. So psoas major, psoas muscle, quadratus lumborum, and the iliacus. Here, iliacus muscle. So try to search them during our dissection. So these are, the psoas major muscle is a long, thick fusiform muscle that lies lateral to your lumbar vertebra. And then your iliacus muscle here, lateral to the psoas muscle. It is the triangular large muscle alongside lateral to the inferior part of the psoas major. And your quadratus lumborum is a thick muscular sheath in the posterior abdominal wall that is adjacent to the lumbar transverse processes. And you also have 5 lumbar vertebra and associated discs. You have your posterior abdominal wall muscles, your diaphragm. What I'm saying are the structures that's located at the posterior abdominal wall, okay? And you have the fascia, that including the thoracolumbar fascia, your lumbar plexuses composed of the anterior rami of the lumbar spinal nerves, fats, nerves, vessels, and lymph nodes. Now, next slide is take a look at the abdominal aorta, where we should see three single arteries that supplies the digestive organs, and six paired. These would be your suprarenal, renal, gonadal, that goes to the urogenital and reproductive organs. You have your subcostal, inferior phrenic, and your lumbar that goes to the diaphragm. You have 6 pairs and 3 single arteries. And on the left side of the frame, you would be able to see the venous drainage, the inferior vena cava and its tributaries. Okay, so is this the last slide? Yep, that's the last slide. So don't forget, this is quite a long lecture, but it's quite easy to remember, except maybe for the inguinal area. Kaya merong mnemonics akong nilagay. So if that could help, I hope that you would get a perfect score during the quizzes. And yeah, that's it. That's it for today. And you can have your break unless there are some more announcements. May questions ba? Do you have questions that I could answer now? Yeah, intermittent fasting will not get you those abs. You have to do exercise alongside with caloric restriction, increased protein intake up to 2.5 kilocalories per kilogram, body weight per day. Any more questions? May announcement yata eh. So we'd just like to inform everybody that you should bring your lab manuals with you during the laboratory sessions that we will have. And let me just close my screen. This Yeah, I'm still here. Questions, clarifications?
Are there questions for Dr. Paculan? So silence means yes. So if there are no more questions, or again, mahiyain tayo, andyan yung discussion board. So type nyo na yung question nyo doon. And para lahat mag-benefit. Okay? So few announcements. So back to regular programming, back to our daily grind. So we'll start tomorrow with the first laboratory for second sem. But before the lab session, feedback tayo, no? So lahat papasok ng 8 o'clock kasi simultaneous yung feedback natin. So there are subsections for all sections, divided kayo, no, into subsections. So kindly check the Facebook and Canvas for the room assignments, no? So everyone will have their feedback and immediately followed by the lab session. So those who will be assigned sa sa histo, no? After the feedback, you'll start with your respective laboratory session. So kung gross kayo, akit kayo. Kung histo, you stay there. And then those assigned at sa JMC, so after the feedback, so that's ISP. Pero syempre, di ba, maximize the time. You may start studying on the models, the bones, or kung gusto niyo histo book, no? So aral kayo doon. And then, marami nagtatanong, may quiz ba tayo this week? No quiz for this week. Next week na tayo magsa-start ng laboratory quizzes. Okay? And then, with regards kung ano yung activity nyo for this week, kindly check. We already posted the lab activities for this week. So, kung gross kayo again, wear scrub suits, rubber shoes, no Crocs. No Crocs. Hindi pa kayo mag-OR. So, walang magko-Crocs. And kung sino naka-assign sa histo, complete uniform. Leather shoes. Walang naka-rubber shoes. Walang Onitsuka pero black. Kailangan leather shoes. Okay? Sinong subsection nakalagay yon sa ano? Nakalagay siya sa Facebook and nakalagay siya sa Canvas. So check niyo na lang kung sino yung nasa histo, sino yung nasa JMC. Okay? So, any more questions, clarifications? So, none? Okay, so we can call it a day and see you tomorrow. See you this week.
Thank you po.
Thank you
Thank you po,
po, Doc.
Doc. Po.